Hello, everyone, and welcome to our Fact versus Fiction annual luncheon. I'm Eva Dubin. I think maybe I know a third of the room, but for those who I don't know, I'm the founder of the Dubin Breast Center. When I first had this vision, I realized there was something simple but yet crucial missing from breast cancer care. A place where women could receive all of their care under one roof, delivered with compassion and excellence, and regardless of ability to pay. 14 years ago, we opened the Dubin Breast Center with that mission in mind. And to be honest, I was not sure that anyone would walk through the doors. Neither was Dr. Port. But you guys did, and you kept coming. And today we see between 180 and 200 patients a day. And last year, we did over 12,000 mammograms, and we operated on 900 women and men. And thanks to you guys, we are also saving women's hair. We have saved over 500 women's hair since we started in our cold cap therapy program. And that is all covered by philanthropy, so no one gets charged. Today, we have an impressive panel of experts, so get ready to learn what's fact, what's fiction, and maybe what's something in between. Thank you for being here and for believing in our mission. Now it's going to be my privilege to introduce our next speaker, Vanessa Rissetto. I said that right? Oh, good. Vanessa is a powerhouse, an accomplished dietitian, CEO, and co-founder of Culina Health, and a passionate advocate for inclusive, accessible care. But today, she's not here as a leader in nutrition. Today, she's here as a patient. And Vanessa is here to share her story with you. So please join me in welcoming Vanessa Rissetto.
Hi. Okay. I learned how to be a clinician within the walls of Sinai, so of course I would get my care there. In May of 2023, I went in for a routine mammogram. I wasn't expecting anything. I was a busy mom, running my company, managing all the moving pieces of life. But then a call came, and suddenly I was in a new reality. A biopsy, a diagnosis, cancer. Everything blurred. Sorry, you know when you get cancer and then you cry all the time, except before I was like emotionally barren, and now my kids are like, Mommy, you cry so much. I'm like, I know, it's so crazy. Okay, everything blurred except for one moment. The day someone said to me, I don't know who you are, but a lot of people care about you. And that really stuck. Because in a moment where I felt stripped of everything, my safety, my certainty, my sense of control, that sentence reminded me I wasn't alone. 3 days later, this is also my love letter to Dr. Wells and Dr. Tiersten, because I love them so much, I love you. 3 days later, I was sitting with Dr. Christina Wells, and she was like, okay, hey, it's gonna be okay. I'm like, are you sure? She's like, I'm pretty sure you're gonna be fine. And then a week after that, Dr. Amy Tiersten, again, need for validation. I didn't get a lot of hugs growing up. Am I gonna be okay? Yes, you are, okay. And then 2 weeks later, I had surgery. That's how fast it moved. But emotionally, I was still stuck back at that mammogram, trying to make sense of it all. I didn't feel brave. I felt really terrified, not just of what was happening to me, but of how to keep going. I didn't want my kids to see me sick. I didn't want my team or investors to think I couldn't keep leading. I didn't want to lose everything I'd worked for. And yes, I did not want to lose my hair. And instead of being told to just be grateful or focus on getting better, my doctors listened. They let me ask the same questions again and again. Sorry, guys, I promised to send good Christmas gifts. They made space for my fear. They made room for my ambition. When I said I couldn't afford to disappear, they didn't shame me for that. They problem solved with me. And so Dr. Waltz always makes me feel like I am her only patient. I'm always like, I'm sure there's a bunch of people waiting outside, but it feels like it's just me and you right now. And Dr. Kirsten also, when I didn't know if I was going to show up for surgery, literally the day before, she was like, okay, I'm going to see you in the OR tomorrow. Do not worry. I was like, okay, it's going to be great. All that to say that these people are behind me. I asked them the same question 85 different ways. I learned that from investors. It really does prove to be useful. And they answer, and they don't get annoyed, and they call me back into their office. And so they didn't just save my life, they actually honored my whole self, mother, partner, founder, human. And honestly, that kind of care is truly rare. And that is what carried me. It has been almost 2 years now. The ride hasn't been smooth, but I'm still here with my kids, with my work, with my life, and I'm so grateful to them and to this place and to all of you for supporting Dubin and all of the good work that they do. So thank you.
Thank you so much, Vanessa. Patients like you inspire us to push harder, to think bigger, and always keep compassion at the center of our care. Hi, everybody. I'm Dr. Lisa Port, Director of the Dubin Breast Center and Chief of Breast Surgery at Mount Sinai, and it is such a joy to see this room filled with so many friends, supporters, and new faces. Welcome to our 2025 Fact versus Fiction Luncheon in our new space, because we sold out the last 2 years in a row. So you made it happen, and that's why we're here. First, a big thank you always to Eva Dubin, my partner in the mission, and the woman who turned a vision into a vital reality. Thanks to her leadership and generosity, the Dubin Center has become a home for world-class, patient-centered breast care in New York and far beyond. Eva, I'm so grateful to be on this journey with you. May it continue for a very, very long time to come together. So as many of you heard, scientific discovery guides our approach, but patient care really remains our core and our passion. At Dubin, we're treating more than just breast cancer. We're caring for the whole person, mind, body, and spirit. Last year alone, we launched even more groundbreaking clinical trials. We expanded our reach with our 1,000th mobile screening event, which gets to unserved populations for screening with mammograms. And we continue to harness new technologies so that AI works for us, not instead of us. I definitely promise you, even though you'll hear more about AI in a bit, you will never show up to a mammogram and be greeted by a robot. Fact versus Fiction is definitely one of my favorite events because it combines two of my passions, which is patient education and correcting all of the crazy things I see on the internet, very specifically Instagram. We're living in a time where mistruths abound. We say that misinformation can travel around the world before the truth has even put its shoes on. But the good news is that evidence, data, and science still win when we share them widely and clearly, as we will do today. And by the way, from my standpoint, the irony is that the real truth is a huge source of optimism. It's the misinformation that takes people down rabbit holes. For example, how about starting with this fact? The newest data released just a few weeks ago, this is all new information, shows that between the year of 2010 and 2020, the survival rate of women with breast cancer between the ages of 20 and 49 went up by 80%. And how about another fact? You were asked a question on your way in today. Fact or fiction? The average age of a woman getting breast cancer is 60. 11% of you said fact, and 89% of you said fiction. So this is clearly an opportunity for education, okay? While many young women do get breast cancer, and there's no age where you're too young, yes, the average age of women who get breast cancer is 60, okay? It is predominantly a postmenopausal disease, right? And there you have it. So while women of any age can get breast cancer, the fact is that most are postmenopausal. So if we've taught you nothing else, there's one fact. Third fact, incredibly, the overall survival rate from breast cancer is now 91%. So we're in an era of precision medicine, and that means more people are not only beating cancer, but coming out healthier, stronger, and ready to take on the world, just like you heard from Vanessa. The best way to fight misinformation is with clear, truthful information, and that's what my panel, our amazing doctors, are going to do today. They're not just experts in their field, they're also committed to truth-telling. And they also meet people where they are. They'll be sharing the latest insights on everything from breast health, hormones, diet, exercise, cancer screening, cognitive health. This is a new additive this year. And yes, we are definitely open to questions that you are even too embarrassed to Google. So save them up. So enjoy your lunch, open your minds, and get ready for a lively and informative and hopefully entertaining conversation. And it is a conversation. We expect full participation. So with that, let me introduce you to my panelists. I can honestly spend about 10 minutes on each of them, introducing them, because each is so accomplished and so outstanding in their own rights, and their credentials are endless. So I'm going to abbreviate to allow us to get to the heart of our program. Our first question is a combined question, and we're going to start with a breast cancer question before we move on to more general health. And it's for our first two panelists, so let me introduce them. Dr. Christina Welts, who you already heard a bit about, is a breast surgical oncologist. Her work spans technical excellence, quality of life research, and even the psychological aspects of delaying diagnosis and treatment. She's also, I'm very proud of her, she's the director of our breast fellowship program. So she's training the next generation of us, breast surgeons, in the highest standards of care. And then Dr. Amy Tiersten, to her left, as you heard, is a professor of hematology and medical oncology and a central figure in breast cancer care at the Dubin Breast Center. She leads most of our clinical trials, both as an investigator. She's also a leader in national clinical trials. So the question for you two together is, when most people are given a new diagnosis of breast cancer, most do have surgery first. But we're in an age where there's no one size fits all, and some are referred for treatment first, i.e. chemotherapy. How do you two, as the breast surgeon and the medical oncologist, make the decision regarding who needs what and the order? And we have so much to cover. We're gonna keep the answers short so we have time for Q&A at the end.
Elisa, thank you so much. Vanessa, thank you so much. Thank all of you so much for being here. It's a wonderful event. Let me talk about how we approach this question from a surgical point of view. It's absolutely true what Elisa said, that historically, we virtually always treated breast cancer by starting with surgery. Keep in mind that chemotherapy did not come into widespread use until the late 1970s and 1980s, so there really weren't a lot of options that were available. But in recent years, we are very, very frequently flipping the order and doing systemic therapy, such as chemotherapy, hormonal therapy, before doing surgery. The term that we use to describe these therapies that are being given before surgery is neoadjuvant therapy, so you might hear us use that terminology. The oldest and the most basic reason that we flip the order is simply inoperability. And the term says it all. You would not want to operate on breast cancer that is inoperable. So I don't know if you've experienced this. Sometimes in watching a melodramatic movie or a TV show or even a soap opera, you'll hear about some poor unfortunate character who has an inoperable malignant tumor. And you'll sort of say to yourself, that doesn't sound great, but I have absolutely no idea what they're talking about. So let me explain to you what inoperable breast cancer means. Essentially, inoperable breast cancer is any breast cancer that if one were to try to do surgery or if one were to mistakenly do surgery, you would violate the most fundamental principle of cancer surgery, which is to never cut through cancerous tissue. You always want to resect cancer by taking it as a whole and going widely around it. So a couple of examples of inoperable breast cancer. Elisa just mentioned that I am very interested in why people delay their diagnosis and treatment for breast cancer, and we do frequently see patients who come in with locally advanced breast cancer, where the cancer may be attached to the muscles underlying the breast, attached to the skin overlying the breast, and you cannot do a mastectomy without violating those principles. We also see inflammatory breast cancer, which you've probably heard of. It's a very aggressive form of breast cancer, where from the very beginning, cancer cells have worked their way into the thick layer of the skin called the dermis. And if you were to try to operate on that up front, you would inevitably cut through cancerous skin. So our job as breast surgeons is to recognize inoperability. Sometimes it's incredibly obvious, sometimes it's quite subtle, and instead of doing surgery, refer to our colleagues in medical oncology to treat first with these neoadjuvant therapies. Let me finish with one last other thing. A very important recent theme in the treatment of breast cancer is the concept of de-escalation. This is a Vietnam War term that has been applied to the treatment of breast cancer. De-escalation essentially means less is more. How can we give less chemotherapy? How can we give less toxic chemotherapies? And it's safe to say that as it relates to surgery, we cannot de-escalate therapy, surgical procedures, without the use of neoadjuvant therapy. So imagine a woman with a large tumor. It's operable, but you'd have to do a mastectomy or a very large disfiguring lumpectomy to get it out. You can use neoadjuvant therapy in selected cases to shrink that tumor and be able to do a very attractive-looking, cosmetically acceptable small lumpectomy. Similarly, if a woman presents with known cancer in her lymph nodes, we as surgeons up front would be obliged to do an axillary dissection, taking out most or all of the lymph nodes, which can lead to very dire consequences, most notoriously swelling of the arm or lymphedema. But if you can give therapy first and knock the cancer out of those lymph nodes, you can then do a minimalistic axillary surgery and avoid that type of morbidity and side effects. So I'm now going to pass it on to Dr. Tiersten to talk more from the chemotherapy point of view.
Hello, everybody. Thank you, Elisa and Vanessa, and it's wonderful to be here, and thank you all for being here. So from a medical oncology point of view, the most important reason, the most important advantage of giving neoadjuvant or systemic therapy prior to surgery in the form of chemotherapy, immunotherapy, targeted therapy, is that we get to see how well the treatment worked. And that gives us very important information about prognosis and about what is the best way to treat the patient after surgery. So for example, if a patient has neoadjuvant, and this is particularly true for the subsets of breast cancer that are called HER2-neu positive breast cancer and triple-negative breast cancer, because those are the therapies that are most responsive to neoadjuvant therapy. And we give a course of treatment, and the patient then goes to surgery, and one of two scenarios can happen. Either there's no residual cancer cells in the surgical specimen, or sometimes there are some residual cancer cells in the surgical specimen, not in the patient, but what's already been removed. And remember that the systemic therapy is not just to shrink the cancer down, it's also to treat any microscopic disease that might be elsewhere in the body. And if we find resistant cells in the surgical specimen, there might be resistant cells elsewhere in the body. And it's been shown that giving a different systemic therapy after surgery drastically, about 50% reduction, reduces the risk of a later distant recurrence. So to miss getting that very important information about how well the treatment worked and what we need to do differently is the most important advantage. One other important point is that certain therapies, in particular immunotherapy are drugs that allows a patient's own immune system to fight the cancer. So immunotherapy really only works if the tumor is present in the patient, because the tumor needs to be there for the immune system to detect and fight the cancer. And so that's another very important reason that if you want to give someone the benefit of immunotherapy, it actually has to be before surgery.
Wonderful. So moving on to Dr. Khalil. Dr. Susan Khalil is an OBGYN board-certified minimally invasive gynecologic surgery. She brings both advanced skill and deep compassion to providing care in the gynecologic arena of women of all ages and all stages of life. And she specializes in hormones. So we know the world is blowing up now with information about menopause and hormones and what to take and who can take what. And it's a big area of interest for women of all ages. So for Dr. Khalil, let's start off with, what are the options for management of the different menopausal symptoms? And we know these differ for women both with breast cancer and without. So tell us a little bit about what the approach is for those two different groups. I guess 1 minute for each.
All right, well, I can talk endlessly about this topic, but thank you so much for your attention today. I think a precision approach is really important. You hear a lot about menopause in the community at this time, and it's gotten a lot of attention. But the way to approach it really is from the systemic perspective, meaning are you having hot flashes or sleep changes, cognitive changes that are really bothersome during this transition? Other ways to approach it is if there's a history of breast cancer or if there's no history of breast cancer. And that really governs, should we do a deep dive into medications that are non-hormonal, which there are newer agents that are centrally acting and can really impact vasomotor symptoms, which are hot flashes. There are hormonal treatment options, but those options cover a wide array of different kinds of symptoms. So really talking to your physician about what is most bothersome and what's safe depending on the surgical procedure that you had, the receptor status on the specimen. These are different key conversation points on managing your care. On a completely different note, there's vaginal symptoms, which are very different. There's a concept of genitourinary syndrome of menopause, where many patients present with this, where there's vaginal dryness, recurrent urinary tract infections, and dyspareunia as well. And these can be really managed in such a great way with a lower risk tier of agents that include non-hormonal vaginal moisturizers, lubricants, and things that can target the mechanical tissue, where you can have pelvic floor physical therapy and other agents that really help support, so quality of life is improved. I'm going to stop right there because I can go on. So,
but tell us one more thing about the new medication for the vasomotor symptoms, because I think that's an important one that a lot of women have not heard about. It's very, very new.
So I'll start with that one. So I have no conflicts of interest on this, but for simplicity, it's called Veoza. And that one helps target hot flashes specifically. It doesn't quite target all the other symptoms, and that's why it's really important to understand which menopausal symptoms are most bothersome to you, because choosing this medication won't cover at times sleep changes and mood changes that can also accompany menopause. And I'm going to cover the question that nobody wants to Google, sexual health and sexual function and libido. There are newer drugs that are also available right now that haven't been available within the last 2 years that are specific for postmenopausal libido or hypoactive sexual dysfunction versus premenopausal, which is managed in different ways. So there are newer drugs that are on the market, they're centrally acting, and they're worth a conversation with your physician.
To be continued. I'm sure we'll get a few more questions along those lines. So next on my panel is Dr. Lori Margulies, who is well known to many of you, she is the chief of breast imaging at Mount Sinai. She's known for her groundbreaking work in breast MRI, 3D mammography. Never get tired of bragging that we were the first ones in all of New York to have 3D mammography. Now about 50% of centers nationwide have it. It's all because of Lori and her vision to bring it into the Dubin Breast Center. And she also does a lot of research in breast density. She leads our mobile mammography program, and this really brings life-saving screenings to a lot of different communities across New York. So last year, Lori, you talked to us a little bit about AI in radiology, and you shared that we were the first ones in New York also to double read every mammogram with AI, regardless, with no payment, with no added payment. Tell us what is the update on AI in imaging and the Dubin Breast Center.
So, thank you for those absolutely kind words, and thank you to all for being here, and thank you especially to the 12,000 women who had their mammograms at the Dubin Breast Center last year. So AI has continued to grow over the past year. It reaches every facet of radiology, not only breast imaging. In mammography, the algorithms keep improving, meaning they're finding smaller and smaller cancers and marking less things that are irrelevant. And they're changing. Soon the algorithm will be comparing with priors, which makes it even more sensitive and more specific. Soon the algorithm will be able to detect if your breast arteries are calcified and you might be at risk for cardiovascular disease. As less and less women die from breast cancer, more and more women are dying from cardiovascular disease. It's a very important thing. We're also learning how to use it better, meaning we're learning to respect it. So if the AI is really, really worried about something, but it doesn't look that worrisome to me, I might just go with the AI. And just like was said before, call somebody back for that additional images, because maybe those special magnification views are going to show something that my eye couldn't see, but the AI could figure out. So we're really learning to respect the AI. AI also knows things that we don't know. So now there are programs that are looking at the mammogram and saying, okay, we don't see a cancer now, but this is a high-risk patient. And those algorithms are a little bit better than all those questions that you fill out about your mother, your grandmother, your aunt, and all those questions that everybody hates answering. But actually the AI is better. It's about 10% better than those. So maybe we'll be getting that at some point. AI is also being used to shorten the MRI exams. It may be used for AI detection on MRI. And lastly, some of our younger colleagues and residents are looking at ChatGPT and other similar models on making our reports better and easier to understand.
Great. Our next panelist is a newcomer to Fact versus Fiction, and so excited to have him here, Dr. George Nassan. He is a neurologist, and he's an expert in behavioral neurology and neuropsychiatry. At Mount Sinai, he serves as the medical director for cognitive health. His clinical and research work centers on dementia and improving quality of life for people living with it. So as we're all living longer and surviving breast cancer more, we're all concerned about our cognitive abilities as we get older. So Dr. Nassan, what are the cognitive changes that we often associate with menopause? And what do we think those changes are related to, and are they real? On top of that, how might breast cancer treatment either accelerate those changes or contribute to those changes in any way?
Thank you so much, first, for having me. Really, it's an honor to be here, and thank you to everybody for being out here. Around menopause, it's actually not uncommon for women to experience cognitive symptoms. So about maybe up to 2/3 of women can have this. The cognitive symptoms usually are around the lines of difficulty with working memory. Working memory is the type of function that you need. Like if I were to give you a phone number right now that you need to retain it long enough to dial it, That's kind of what you need. People become a little weaker at stuff like that. But also it may affect things like learning and therefore sort of memory. And a lot of these symptoms actually just go away, later on. They don't necessarily linger. And there is no real consensus about what's causing that, but there seems to be some relationship with the loss of estrogen, which is protective from aging and protective to the brain and to cognitive health. But also around menopause, there's a lot of other reasons, why that could happen. Women could be experiencing poor sleep or low mood, so there are other factors, that could be contributing to this. In women who have breast cancer that may be receiving medications that lower estrogen or block the function of estrogen because of the type of their cancer, depending on which one they have, because of the lower availability of estrogen, they could also experience similar symptoms. They're usually mild, and we might refer to them as mild cognitive impairment. And these could be seen in some types of lowering agents more than others. But the jury's still out, on this. Not everybody sort of gets that. And I think there's still a lot to learn, about all of that topic.
And we can talk more in an interactive way with the other people who are in charge of giving that medication.
Absolutely.
And what they see. Last of our first round of questions. Dr. Jeffrey Mechanic is one of our secret weapons at Mount Sinai because he wears many hats. And if you've been to Fact versus Fiction before, you've probably seen him. We'll take him whenever we can get him. He's a professor of medicine. He's the metabolic director of the Center for Cardiovascular Health, and he's the director of metabolic support and endocrinology. He has multiple leadership roles in national organization, and he's a pioneer in lifestyle medicine, nutrition, and complex systems analysis. His work really bridges cardiology, endocrinology, and preventive health. So one of the biggest topics right now is the GLP medications. Given that being overweight, Dr. Mechanic, is a known risk factor for breast cancer and breast cancer recurrence, how can we leverage and use the GLPs to reduce that risk? And how should we think about the GLPs as a potential indicator of modifying risk for breast cancer?
Great, thank you. Thank you, Elisa. Thanks, Eva, for having me. It's really a pleasure to be back, to see everybody. Enjoy your lunch while I talk about weight. So let me define some terms and connect the dots for you. So GLP-1s, GLP-1s, glucagon-like peptide 1, and it's a receptor agonist. So this is a substance, a compound that interacts with a receptor that you have in your body. In fact, your body actually makes these drugs. So they're like biologics. Your body makes them already. And there are 4 broad types that are out now. You've all heard of Ozempic, and you've heard of Wegovy. That's semaglutide, and that is a compound that just hits the GLP-1 receptor. And then there's tirzepatide, which is Mounjaro and Zepbound. And that hits both a GLP-1 and also a GIP, gastric inhibitory peptide receptor, also made by the body. And what they do when they were first sort of developed, and by the way, these compounds, they were kind of developed and invented at Mount Sinai. Back when I was a fellow, an endocrine fellow, they were being researched at the Bronx VA, and they derive from, colloquially, lizard spit. But the Gila monster, that if you've ever been to Scottsdale and you go on the desert tour, there's the Gila monster out there. And basically in the saliva, it has something that lowers the blood sugar, the prairie rat that it then eats. And it was looked at for diabetes. So these drugs were developed originally for diabetes, and they work. And then they were finding that these patients with diabetes were losing quite a bit of weight. So then these drugs got FDA approved for diabetes, and that would be Ozempic for semaglutide or Mounjaro for tirzepatide. That's why it gets confusing when you're asking your doctor which one should I be on. And for obesity, the FDA says, well, it should be Wegovy for semaglutide or Zepbound for tirzepatide. So now let's connect the dots. We know statistically that when we have extra weight on the body, we are at increased risk for cancers, all kinds of cancers, but particularly for breast cancer. Those data exist. But there's a mechanism behind it, and here's how it goes. Here's the narrative, the story. As we eat more than we should, right, we put on extra fat on our body where we store it. But it doesn't even have to be the fat that's under the skin that you see in the mirror. It could be fat around the heart, fat in the liver, fat in the kidney, fat in the bone marrow, in the muscle, in the pancreas. And this fat is very inflammatory. It's not supposed to really be there. It causes insulin resistance, hence the diabetes down the line. As a result of insulin resistance, now your insulin levels go up. The insulin kind of gets confused and starts hitting a different receptor, insulin-like growth factor, and now that promotes cancers in the body. So you're at increased cardiometabolic risk, and you're at increased risk for various cancers. So clearly, being on a medicine that can lower your body weight, lower this abnormal adiposity, now I'm losing my voice, lowering your abnormal adiposity would be good for you and lower your risk for cancer. So the real question is, what if you're not obese? What if you don't have diabetes? Should you ask your doctor whether you should be on these medicines? And the answer is definitely you should have that conversation. And there are indications that are legitimate indications to go on these medicines. For instance, if you're at higher risk for cardiovascular disease, for sleep apnea, and there will probably be emerging indications down the line to go on these medicines. So let me stop there, and
More
we
to
can answer
come.
questions later.
Riveting, obviously an incredibly popular topic. So this is the point in time where we can, I have many more questions for our panel, but if other people have questions, we have people in the audience who will come around to you with a microphone, or if you're too shy to ask, as we said, too embarrassed to Google, and you can ask them here. You can also write them down on a card, and there'll be people coming around to collect those. To start back again with Dr. Welts, this is, we haven't talked yet about BRCA, the PRCA genes. It's a really, really important topic that, as we know, BRCA genes disproportionately, anyone can have a BRCA mutation, but they do disproportionately affect the Ashkenazi Jewish population, which we take care of a very significant number at Mount Sinai. So, Dr. Welts, tell us a little bit from the breast cancer standpoint, what's new in the management of BRCA patients?
I'm going to answer the question from a Dubin breast-centric point of view as to research that is happening now, and also from the point of view of this being a fact versus fiction. And then I would welcome any specific questions about the BRCA mutations. I don't think there's any topic related to breast cancer that's associated with more myths, more fiction, more misconception than the BRCA1 and 2 genes. In fact, how many percentage of you said no to the average age of breast cancer being 60? My question...
90%.
Right. So can you raise your hand? I don't mean to be obtrusive, but did you think it was older or younger? If you thought it was younger, just raise your hand for 5 seconds. That's most people. That's a lot. So that could well be a reflection of people assuming that the BRCA genetic mutations are far more prevalent than they are. But let me speak to, because it is absolutely true that women who have BRCA mutations, particularly BRCA1 mutation, their average age of getting breast cancer is in the early 40s, very different from the age 60 that we learned about later. That may have influenced your answer with regard to that. One of the misconceptions about the BRCA gene that can be actually deleterious is the misconception that it can only be inherited through your mother's family and that your father's family has nothing to do with it. And while it's absolutely true that men who carry a BRCA1 or 2 mutation get off relatively easy compared to women. And we can talk, if you want, about the risks of breast cancer, ovarian cancer, pancreatic cancer, and prostate cancer, which obviously affects the men. This is a misconception that affects many patients, and believe it or not, many doctors who take care of these patients. So here's a typical conversation. I might be seeing a young woman of Ashkenazi Jewish descent, perhaps, who has been diagnosed with breast cancer. And she'll tell me, I don't possibly have a BRCA gene. I cannot possibly have that gene because there is no family history on my mother's side of breast or ovarian cancer, or any cancer for that matter. And then you probe further and you learn that the patient's father's family is linked to breast and ovarian cancer, maybe the father's sister, maybe the father's mother, maybe the father's aunt. And you do genetic testing, and lo and behold, that woman carries a BRCA gene. So with regard to what's going on at Dubin right now, one of our fellows, Erica King, has been working mostly with Elisa on a project which is very, very interesting. It's looking at all of our women with BRCA genes whom we've treated over the past decade or so, and asking the question, does maternal versus paternal inheritance affect the stage at which you present, or the degree of mammographic and MRI and other screening that an individual has had? And lo and behold, the data are showing that women who inherited through their father's lineage are presenting with later stage cancer in the context of a BRCA gene. So like everything, we want to get the truth out, get the word out, encourage people to get tested, and I think we excel at that at Dubin. And when a woman is diagnosed with a BRCA mutation, through excellence in surgery, excellence in screening, and excellence in giving information, largely thanks to our great genetic counselors, I think we do a really good job.
Great. I'm actually.
That was a plug for you.
Thank you. I gotcha. Thank you. I'm going to skip over Dr. Tiersten for a second, because the flip side of we have a gynecologist here, and as we talked about, BRCA primarily affects the two big cancers, are breast and ovarian. And I think there's a lot of controversy about what timing to prevent. In order to prevent ovarian cancer, we remove the ovaries. But there's a lot going on now with removing the tubes. Because ovarian cancer supposedly often originates in the fallopian tubes, does removing the tubes first and preserving the ovaries so you get those few added years of estrogen, let a woman delay removal of the ovaries and protect her in any way by removing the tubes first?
Thank you for that question. I think one of the things that's very exciting at this point in time is actually the role of the fallopian tubes in the development of serous ovarian cancer. It's a specific type of ovarian cancer, and it's one that there's a current multi-center trial that's looking at this, whether removing the tubes alone and then delaying ovarian removal helps with patients having added bone health, cardiovascular health, and the other benefits of retaining their ovaries. And it's one that's very promising, but it has to be tailored, I think, depending on your risk factors. But opportunistic salpingectomy, which is removing the tubes as a preventative option, is something that can reduce the development of serous ovarian cancer from anywhere from 40 to 70%. So that's actually a really new, exciting thing that we've noticed in the prevention, where we've had really very little in the prevention of ovarian cancer, but there's a lot that we've learned along the way, specifically from BRCA1 and 2 patients, where we found out that the fallopian tubes is where some of these cancers for ovarian cancer originate. So that's a new development that's worth sharing.
Going back to Dr. Tiersten, there's been a lot of renewed interest, of course, in hormonal treatment and therapy. The question is, in patients with a history of breast cancer, is there ever a role, under what circumstances, if any, is it considered appropriate or safe to offer hormone replacement therapy, or even just estrogen alone, because replacement therapy is usually a combination of estrogen and progesterone? Is it ever safe to do that?
Well, Lisa, about 70% of breast cancers are driven by estrogen. So they have the estrogen receptor, and anti-estrogen medication is incredibly effective therapy, life-saving therapy, to reduce the risk of those cancers coming back. So you would imagine that adding hormones in the form of hormone replacement therapy might increase risk. And in fact, randomized trials that have compared hormone replacement therapy to placebo in estrogen-fed breast cancer patients show about an 80% higher risk of recurrence, and the trials were actually stopped early because it was unsafe to continue. Then you might say, what about estrogen receptor negative cancer or triple negative breast cancer? And there, some important points are that about 20% of the time, if a triple negative or estrogen receptor negative cancer recurs or metastasizes, about 20% of the time it does so as a hormone receptor positive breast cancer. So that's either perhaps at the time of diagnosis there was actually a mixed population of cells, or actually the receptor converted. And so I think that's concerning that 20% recur as hormone receptor positive breast cancer. In addition, in triple negative breast cancer, there are other receptors that interact with hormones, such as a receptor called RANK, the androgen receptors, ER beta, and those have been shown to also interact with hormones. Lastly, there's indirect evidence that hormones play an important role in triple negative breast cancer, as it's been shown in studies that women who go into a chemotherapy-induced menopause, which is something that happens frequently in women receiving chemo over the age of 40, actually have a lower risk of the triple negative breast cancer recurring. And likewise, women who remove their ovaries, typically for a BRCA diagnosis, for example, also lower their risk of a triple negative breast cancer recurrence. So unfortunately, I would have to, give a general answer of no, but on a positive note, there's a lot of research over the last number of years on how to treat the symptoms of estrogen deprivation, which is a lot of what we do as medical oncologists. And vaginal estrogen has been shown to be safe in some forms. Acupuncture can help with hot flashes. There are medicines that Dr. Khalil talked about with regard to hot flashes. There are bone strengthening agents and others. And so we work very hard to help with the symptoms of estrogen deprivation in other ways.
Great. And anyone who has a question can start raising their hand. I'm gonna go to one more from my list, which is to Dr. Margulies. Okay. No shockaroo here. No one loves a mammogram, okay? I recently did a podcast with Molly Sims and Emma Shea Gormley, who's here, and we talked all about mammograms, and all of the comments below from the peanut gallery were, when I was advocating for mammograms, were, she has no idea what she's talking about. Do thermograms, do QTs, do sonograms, do this. The whole world is an expert on breast cancer screening, except for the people who actually do this for a living. So, Laura, you are the expert on breast cancer screening. Tell us what's new. What are the technologies that are worth looking at or not, or coming down the pike?
So first off, I think we need to flip the script. From nobody loves mammograms to this thing that was uncomfortable for a few seconds saved my life. I think that is really where we go. Okay, I'm done. All right. So that being said, mammograms are getting better. They're getting shorter. The radiation dose is minimal now. It's not getting any higher. If you flew out to California this year, you got as much radiation as from a mammogram. So it's low radiation. Why not only ultrasound? Ultrasound is great for finding small invasive cancers. It misses, however, the smallest cancers. The stage 0 cancers, it's not going to find. It's going to miss cancers. MRI, it's great. It's not for everybody. Is it getting better? Absolutely. But what's coming down the pike? What are some new things that people are talking about? Okay, breast CT. They sell these machines that are about the size of a table. You lay down, you get IV contrast, and you get some kind of a CT of the breast. Misses part of the breast, doesn't include under the arms. Not great, you still need a mammogram. after it. Liquid biopsy, you get a blood test, misses 2/3 of breast cancers. Not a great test. You want something simple that's going to be sensitive and specific. Coming down the pike, which might be really good, MRI without contrast. Using AI to be able to use all the different sequences that we might obtain without contrast, putting them together and make it look like you had contrast. People are actively working on that, as well as on being able to use breast MRI at lower field strengths where the magnets are much more open. Contrast-enhanced mammography, it's a mammogram, but you get IV contrast. The problem I have with it is people get reactions from IV contrast, from that CAT scan contrast. If you need it, it's great for screening. The problem is people occasionally, rarely do have serious reactions, even death. And the last thing I want to talk about is molecular breast imaging. We've talked about it before. It's an IV injection of radiation that goes throughout the body. Some of the world's leading experts on it are now removing it from their clinics and moving away from it. So lots will come. Nothing is coming quickly. Thermography doesn't work. Maybe someday it will get better, but right now the mainstays are here to stay, and they're getting only better.
Thermography is touted by a lot of doctors who buy the machine. It's not FDA approved. They can put it in their offices, and they're part of the perpetuators of the myth because, to be quite frank, they're financially profiting on it. If a test is not FDA approved, it's not because the government is slow or they do things better in Europe. It's because it hasn't proven to be effective. And so if someone offers you a test that you have to pay money for, it's usually something that's really not effective or not proven to be effective, and it is part of a doctor's desire to get you to pay for something that they're going to financially benefit from. So proceed with caution. We have a lot of young women in the audience, and I wanted to direct the next question to Dr. Khalil. A lot of people undergo now, childbearing is delayed, so a lot of people undergo IVF. We also have people who undergo IVF for fertility preservation. Is there any evidence to suggest an increased risk of breast cancer related with fertility treatments? We know we have patients who sometimes undergo multiple rounds. How do you counsel them? How do you tell them, sorry, there goes my water, what to do?
Thank you for that question. I do notice, yes, this is probably a topic of interest. With the ovarian stimulation portion, there are hormones that are used during this process, and it can increase the risk. So that's where sometimes there's a pitch for natural IVF cycles that can help reduce that kind of exposure. Alternatively, there used to be the use of GnRH agonists that can help put the ovaries in a temporary state, but unfortunately, they miss out on the reproductive window, so it's not a great idea. So it's really going to be primarily through the stimulation cycles, which can sometimes increase the risk. There's older studies that also look at the ovarian cancer risks after multiple IVF cycles, where there can be additional risks as well. But natural IVF cycles are the current way to approach them, and they use many different kinds of aromatase inhibitors as well during these cycles that can sometimes be very tailored to the specific clinical experience of the patient.
Yeah, so that's important to know that we use different drugs for fertility preservation in women with breast cancer and without. We have a very, very effective non-hormonally based treatment. In fact, they're the drugs used in treating breast cancer. Dr. Tiersten, do you want to comment on this? Just follow up.
Yeah, so frequency in breast cancer patients, the IVF is done in conjunction with an aromatase inhibitor, which is an estrogen-lowering medication. It does make for a little bit less of a good yield in terms of eggs, but it's effective in keeping the overall estrogen levels down, which makes it safer for breast cancer patients to pursue that.
There's a question I understand over here.
so there's two parts of this. Best way to lose weight and the relationship of a tactic on breast cancer risk. So as far as losing weight, one of the problems, and we're starting to recognize this with the GLP-1s, is you lose muscle. That's the issue. So sarcopenia is a kind of emergent disorder now that we're recognizing, which is conferring risk kind of globally for a lot of chronic diseases, and that's decreasing muscle. So ordinarily, when you restrict what you're eating, the calories, and oftentimes it'll be the protein as well, even if you're doing some exercise, the muscle mass goes down. So imagine if your muscle mass is going down, even if weight's coming down, the percentage of fat could go up if you did a body composition analysis. Now, this is a predictor for insulin resistance, and that's your connecting the dots to cancer risk and breast cancer risk. We see that the muscle loss is actually accelerated with these agents. So I've encouraged you to have a conversation with your doctors about using these agents, but your doctor may very well say, no, you know, the risks of these agents for you using precision medicine, as Susan was talking about before, for you in particular, there may be net harm in using these agents because you're going to just lose too much muscle. So then what's the optimal way to lose weight? Number one, really a healthy eating pattern. It's not so much about calories and numbers and weighing the food. It's really about sticking to unprocessed foods, to not skipping breakfast, to having a lot of fiber, having foods as close to their natural format as possible, raw plants or lightly cooked plants. If you're going to have meats, they should be lean meats without a lot of saturated fat, though the Institute of Medicine and the government kind of blew it with the saturated fat thing because there really wasn't as much data available as we thought there was when they were putting out those MyPlate things. So you don't necessarily have to avoid fat. Your carbohydrates should be more fiber, less sweets, less starch, less processed foods, and you need to exercise. And the exercise should not only be your aerobic exercise, but progressive resistance training. Institute of Medicine would say 20 to 30 minutes, maybe 2 to 3 times a week. What we're really recommending is exercise every day, 7 days a week. There is no tolerable upper limit to exercise for a human being, so knock yourself out. And progressive resistance training should really be every day, and just not to hurt yourself, rotate the muscle groups, and make sure that if you're on a GLP-1, you really need to have extra protein with that resistance training to preserve muscle mass. So that decreases your cancer risk, that kind of a lifestyle. Hopefully that answers your question.
There is, though, another part of this, though, that is the causality, right? Which is there is the perception that fat stores in the body are just sort of these passive banks of tissue that sit there, and that's absolutely not true. Fat stores are metabolically active. They make things and they secrete things into the bloodstream. And they secrete a lot of pro-inflammatory agents. We've all heard these terms thrown around. Inflammation is bad, it causes heart disease, it causes cancer. Pro-inflammatory agents are manufactured by fat stores, as are hormones. It's one of the predominant sources of hormone production in postmenopausal women. We talk about the fact that, at menopause, our ovaries start to shut down and we're not making estrogen, but we're still women, right? We don't grow beards and our voices don't deepen, so where does that estrogen come from? It comes from the adrenal glands, and it also comes from fat stores. So there's a lot of productivity. The fat stores are definitely metabolically active, and that's the theory of the causality part of it. So important to know. Lots of questions here. Dr. Nassan, chemobrain. Is chemobrain real? How is it measured? And what can we make it better? What can we do to interfere with the progression of chemo brain?
This is a big question because a lot of people, do experience that, and we don't really understand it very well. And we don't really understand, is it related just to the chemotherapy? Is it related to other factors? How the chemotherapy is acting in the body to get rid of the cancer? Something else? I don't think we understand this very well. But we do see it, and people do come to the office, with these complaints. It is frequent that the chemo brain goes away, after the chemotherapy is completed. So it's not necessarily a long-lasting injury to the brain per se, but it's really the mechanism of it isn't yet very well understood. And it may depend on which chemotherapeutic agent. Are we only talking about, estrogen-lowering medication or something else, like, immunomodulator, so on and so forth. What people could do is when they recognize, talk to your doctors about it. I think this is a very case-by-case specific for each patient type situation, and then being able to have a consultation with either a cognitive specialist if needed, or just with your treating, physician, just to be able to understand how much it may or may not be affecting you and what are things that you specifically can do based on your treatment. I think this is where probably we could start.
Can you talk specifically about, are there any, there's a lot out there, sleep, exercise supplements that are effective in cognitive function? There's certainly enough things being promoted as that.
Yeah, absolutely. There's a lot that we can do in general, for our cognitive health, whether or not this is chemo brain, whether or not this is menopause related, whether or not this is aging or something else. Mm-hmm. And there's a number of risk factors for cognitive, decline that we could take in our own hands and sort of decrease our risk for developing this. For example, people who don't exercise, it is known that they could have cognitive symptoms earlier in life, or sort of if they do develop a cognitive disease, the symptoms might be more intense, for these people than those who do exercise. So exercise seems to play a big role. In our world, we recommend at least 150 minutes of exercising in a week, which may come down to exercising every day anyway, to get you to these 30 minutes every day, 5 days a week, or 7 days a week, gets you to that 150 minutes. The types of studies that were done for cognitive really looked at cardio type exercise. So you need 150 minutes of some sort of like cardio related thing, aerobic classes, jogging, running, so on and so forth.
To increase blood flow to the brain and so forth, yeah?
That's a really good question. We don't actually understand the mechanism. And while one possible mechanism could be that we are improving blood flow and vasculature, there seems to be something else at play. And I think there are some labs trying to find that something else because they really want to bottle it in a pill and market it for people and say, this is what you need to do. But obviously, exercising just gets you whatever this is. But we don't yet know all the chemical factors that are related to the benefit from exercising. Sleep is really important. And so people who don't sleep well, this is also associated with cognitive symptoms. So seeing your physicians if you have any condition like insomnia or you snore, or if you have sleep apnea, which means you don't get enough oxygen during sleep, it would be important to address these factors, and try to, whatever is treatable, treat it. There's a number of supplements in the market, and unfortunately, many of these aren't really well studied, or if they are studied, we already know that they don't really work, but they are still sort of marketed really well, and people spend a lot of money to get these supplements and sort of like buy them and use them, but we don't really have good evidence for it. Some of the things that we could do is, if we have things like vitamin B12 deficiency, treating it, is helpful because vitamin B12 deficiency can lead to cognitive problems. But if your levels are normal, taking extra B12 isn't going to help you. In fact, we were just talking earlier about somebody who had vitamin B12 toxicity because of too much vitamin B12, in their body. And
I know who that person is, and she's related to me.
So we have to be careful there. And then things like fish oil, for example, they don't have necessarily a harm to using them. And in the studies, they suggested a potential benefit, but there wasn't significant statistics really for us to say you should go on like fish oil as a supplement. But they're not necessarily hurtful to use if people want to try. Virtually all the other studied supplements, don't really have any benefit, and people have to be really careful. When we were preparing for this panel, I think we talked about the anecdote of there's a supplement out there called Prevagen. People might have heard it on TV or what have you. You know, Prevagen was studied by sending bottles of Prevagen to people aged 18 years old to 90 without any real understanding of what these people's sort of medical conditions are. And they had them do a computer sort of test before and after them taking this. But also nobody was monitoring how they did the test, or did they actually take the supplements or not. And then somehow the data showed that 3 months of taking this, people did better on this computerized test, than not. But none of this is really actually verified by the FDA or approved. In fact, if you go to their website, every statement has an asterisk at the end of it, and then you have to scroll to the end to see these statements have not been verified by, anybody really. So try to save your money and invest maybe in a personal trainer rather than a bottle of supplement.
Such great actionable advice. And always look for the asterisk when you're taking something on the box. We have one question over there and then one over here.
Yeah, hi, I'm a breast cancer survivor. In 1999, I had been involved with ovarian cancer through work, and so I chose, when I was being operated, to have my ovaries out. And I said, my mother had breast cancer, my sister, my father's mother, and I'm BRCA negative. What's going on? He said, well, you have a gene that we have yet to discover. So what's been discovered?
Yeah.
And can you talk about it? And then I have another follow-up question, but let me let you ask that one first. Answer that.
So let's hear from Dr. Khalil and then Dr. Welts, because we have a lot since 1999 to talk about.
So there's a lot of new panels with genes that sometimes don't have the same strength in prediction for ovarian conservation versus removal. But you bring a really good point that I've been dying to say. The role of the ovaries in cognitive decline has been something where they've looked at population studies and have noted that sometimes for non-cancer indications, ovarian conservation may be of benefit, meaning there's other non-reproductive functions to the ovaries all the way through age 59 through approximately even 64, depending on the study. In terms of the genes that we are very clear on are BRCA1 and BRCA2. There are other genes that have these other associations that I think we find out every 3 to 4 years about the development of them, and then using different risk stratification methods, they're able to tie it, but none that have the same level of quality of evidence that we have currently for BRCA1 and 2.
But let's talk about some of the other genes. So now when someone walks into our office and we do genetic testing, we test for a whole panel of genes that are known to have increased risk of breast cancer, perhaps not as high as BRCA1 and BRCA2, but still relevant. Dr. Welts, do you want to address those, a couple of those?
Absolutely. So it is very common that when we see a patient with a very strong family history, as you're discussing, and it turns out that their genetic testing was done 12 or 15 years ago, we do urge them to update the genetic testing, because in line with what Susan was just saying, in more recent years, we have discovered other genetic mutations that increase a woman's risk, for example, of breast cancer and sometimes ovarian cancer. The PALB2 genes, the CHEK2 genes, the ATM genes, the leaf hormone, there are a list of about 9 or 10 of them. They are not as prevalent as the BRCA1 and 2. They don't have the same degree of penetrance. In other words, the risk of breast and ovarian cancer is not as powerful as it is with BRCA1 and 2. So one thing that someone like you would want to cross off the list is, have I had an up-to-date thorough panel? Different experts in cancer genetics will say different things. There are experts who feel that we have already discovered all of the genes that there are to be discovered. Others will say more work needs to be done, and exactly as you were saying, could there be a gene that has yet to be discovered? Let's assume that we have discovered all of the ones that exist. What goes on within families where there is a prevalence of breast and other cancers and no gene to explain it? It's a little bit of a mystery. There are theories, and these have been researched and proven, that common lifestyle factors might be the reason. Could it be something environmental? Possibly, but we have not really described or discovered anything environmental that we can be certain increases a family or a group of people living in the same neighborhood's risk of getting breast cancer. But it could be certain lifestyle things. For example, one of the major risks of getting breast cancer, which is something that the media does not talk about a lot, is simply not getting pregnant or having children until you're older. We're all guilty, I would say. I had my first child at age 37. I was training to be a surgeon. It wasn't easy. What are you going to do? I tease the medical students when I teach them, have a kid now when you're 20 years old, give it to someone and then take it back when you're able to manage it. Biologically, that's where things are. So if you're in a family where there's an emphasis on education, higher level education, all the women are working, that could be the reason. But it's still a bit of a mystery.
Great.
So my second question, if I may?
Let me get to someone else. We'll come back. Yeah. Great question. I have it here on the card, so multiple minds are thinking alike. So talk to us, guys, about the Gallery test for cancer screening, for genetic. We do genetic screening, but then there's another type of blood test to what's coming into favor is called liquid biopsy. Can we pick up cancers earlier through Gallery? Amy and maybe Jeff want to speak to this?
Yep, so at this point in time, there are several established screening tests that are known to be very effective in saving lives and picking up cancer. So mammogram's a great example, colonoscopy, skin cancer checkups, et cetera. And there aren't large trials that tell us, that finding screening in this way for other types of cancer actually improves outcome, decreases death rates from these cancers. And in a lot of the cases, we simply, at this point in time, don't know what to do with the information. So from my point of view, it's not something that, I would recommend, but I'd be curious to hear what you have to say. What?
I don't really have anything to add to that.
Okay.
Yeah, I think these are all commercially based products that are trying to identify a market, but the big problem is data. Have you done a prospective trial with 10,000 patients and show that the people of the positive test do develop breast cancer or colon cancer, whatever it is? Have you shown that the people whose negative test over the next 5 to 10 years don't get it? That's called sensitivity and specificity. And that's what really makes a test valuable. If you're telling a lot of people you either have or you're going to have cancer and then they don't, you're ruining their lives. So we certainly don't want to do that. And so it's really about the reliability of the data. Next, we were going to go back to a question. Question right here. Yep. Hi.
Going back to the non-BRCA
Yeah.
family.
Yes.
This is a screening and prevention question. What is the protocol for a segment that the public doesn't talk about that often?
Yep.
For male members of families that are high-risk non-BRCA?
Yeah, great question. We can, let me go to Dr. Welts regarding screening, and then we can talk to Dr. Margulies also about the role of imaging in men.
Let me just speak about the risk of breast cancer in men who have a BRCA gene, particularly the BRCA2 gene. It is significantly higher than the norm, but keep in mind that the normal risk for a man to get breast cancer is 1 out of 1,000. As breast surgeons, we love it when a man comes in. We're like it's sort of different, and the surgery is different, and it's very satisfying to take care of a male patients. We rarely see them. We maybe see 3 or 4 or 5 a year, but it's 1 out of 1,000. With a BRCA, particularly, again, BRCA2, the risk, I've never read a report that describes anything more than a 7% lifetime risk. So there is no, Lori, please correct me if I'm wrong, there is no official guideline, even for a BRCA carrier male, to get annual mammograms. Some of them do. I would say most of them do not. We encourage breast awareness, breast self-exam, something that men certainly don't know about, but BRCA carriers do need to know about. It's a lot easier to do a self-exam on a man, for a man, than it is for a woman, and certainly to have clinical exams. For a family where there's no identifiable BRCA gene or no gene that relates to men getting breast cancer, I really do not know of any screening recommendations.
Absolutely concur with that. And I think the most important thing is as Dr. Welch said, it's about awareness. The men come in, the data has shown that men who develop male breast cancer usually come in with later stage disease. I took care of a law professor, a male law professor, in the last year. He was actually featured in our gala video. He had what he thought was a skin lesion and was blown off by multiple doctors until someone realized it wasn't in the skin, it was just deep to the skin, and it was a breast cancer. And so both doctors and patients have to be aware and have it on their radar as one of the things that if you have a skin lesion or a rash on your nipple or a lump directly underneath your nipple, it's not irritation from a t-shirt or a surfboard or a skin lesion, and it's got to be checked. If it doesn't go away in a couple of weeks or so, you've got to get it checked. So it's mostly about awareness in male breast cancer. Lori, do you want to add anything as it relates to screening in men, both BRCA or non-BRCA?
No, I absolutely agree that you can do screening mammograms in men. Almost nobody does, but it is possible. But otherwise, just self-awareness and self-exams are the best thing.
Okay, here's one. We had one more from the audience, and then I'll go to Carl.
Hi, guys. I'm Stacy Pashkow. Thank you to my 2 saviors and everyone else up there. I know there's no such thing as a dumb question, but this is definitely one that I should know. So I think I just didn't want to know until now, but being that I'm about like 12 years out from, and I had no risk at all, right? Not overweight, no BRCA, no smoking, no nothing. Am I at an increased risk now that I'm 12 years out? I took tamoxifen, let's just say for 7 years, had radiation, but did not do a mastectomy at all. Do I have a greater risk than someone else in the room of getting cancer again? I assume yes, right? Breast cancer, I mean?
Dr. Tiersten, do you want to take this?
So, having had a personal history of breast cancer does increase one's risk of developing a subsequent breast cancer, but the tamoxifen that you took for 7 years, in addition to preventing that cancer that you had from spreading to another part of the body, which is the primary reason you were taking tamoxifen, there's a side benefit to tamoxifen and other anti-estrogens, and that it actually decreases by 50% the chance of a new breast cancer, unrelated to the one that you had previously, forming in either breast. Yes.
Very much so.
Yeah.
So great question.
before
Let's make this a general question. How do we screen our patients? We know how to screen our BRCA mutation carriers. They're at the highest risk, and we know how to screen people with no identifiable risk factors. What are the guidelines for screening people who have a family history, but who don't have an identifiable gene? Lori, do you want to take that?
Yep. So again, we go back to what's proven. So what's proven? MR and mammography. So at our highest risk people, we would start screening mammograms and screening MRIs 10 years younger than the person developed breast cancer. So for example,
everyone
if
hear
you-
that? You take the family member, you're diagnosed at 45, and you count back to 35 is when you start.
Right, with the caveat that you don't start mammograms until after 30. So if you develop breast cancer at 32, then your daughter would start screening MRIs at 25, perhaps. Not really, nobody screens under 25, but wouldn't start mammograms till 30.
And when do you add, Lori? I think a lot of people are confused about mammograms. We know who gets an MRI. We know the BRCA mutation carriers do. Who gets an MRI?
So anybody whose lifetime risk of breast cancer is greater than 20%, anybody who had breast cancer below the age of 50 and had a lumpectomy should be getting MRIs by ACR guidelines, by Oncology Radiology guidelines. Anybody who had breast cancer and has dense breasts, again, by ACR guidelines, would be getting yearly screening MRs.
Okay, here's a good one that we're coming into the home stretch here. Dr. Mechanic, can stress cause breast cancer? Because no one in here has any stress levels whatsoever.
Men or women?
Breast
stress
cancer.
cause breast cancer?
Can stress cause cancer? What is the data or lack thereof of the relationship between stress and cancer?
To my knowledge, and I would defer to the rest of the panel, you're not going to find anything compelling that's going to connect the two, because first of all, we don't really know how to define stress as being abnormal for a particular person. So there are certain levels of stress for one person that differ for another person. The second sort of caveat is stress is a normal physiologic response. Stress means the stress response to an environmental stressor, which is what's going on that's stimulating that stress response. Humans do very well with stress, actually. It's actually a survival advantage to have some element of stress. We're designed for it through evolution. There's an evolutionary precedent for we do better with starvation, for instance, than we do with overfeeding, hence the obesity epidemic. So no, I would not put the two together directly. Now, there are indirect reasons why stress can increase the risk. People who are under stress oftentimes give short shrift to other aspects of their health care. So they may not see doctors. Look at COVID, for instance. So during COVID, one of the problems was post-COVID, we had a surge in illness, really, throughout the world of deferred care. People were not taking care of themselves and then came in. So if somebody's under stress, they are not going to be taking their medicine or seeing doctors. And let me just, another real important point is kind of flip it on its ear a little bit. If you have a patient with cancer is so concerned about being diligent with their cancer care, they actually don't give the proper diligence to cardiovascular care, lifestyle, exercising, eating right. So other conditions which could have been modifiable or preventable then appear. So it's actually a very good question about stress reduction as part of the totality of good health.
We could easily, I'm getting the sense, keep this conversation going all day, but unfortunately, our time together has come to a close. A huge thank you to my incredible panelists. They are all so busy and they have such huge demands on their schedules. So to be with us today was so, so special. Your insights and your candor and your expertise are what make this event so meaningful. To all of you in the audience, this unbelievable audience of supporters and patients and friends, thank you for joining us. Your presence here and your ongoing support, it really makes everything we do possible. It really does. We're committed to providing not just excellent care, but exceptional, compassionate care who walks through the door regardless of the ability to pay. And that mission only thrives because of you. If you feel inspired to contribute, there are donation cards at your table. Every gift, large or small, makes a direct impact on our patients' lives. Thank you so much for being part of our community, and we wish you a happy, healthy, and hope-filled summer.